Hi, it's Dr. Centeno, and thanks for joining me today You've Got the Power. We're going to talk today about an interesting topic. We'll talk about that topic first, and then I'll take questions, whether it's about that topic or anything else. And the topic that we're going to talk about today has to do with digital motion X-ray or DMX imaging and C1, C2 overhang, which is a measure of craniocervical instability or atlantoaxial instability, and just trying to make sure that when we compare those films from before a procedure to after a procedure, we're getting an apples to apples type comparison. So again, we'll start with that presentation, and then from there, I'll take questions, whether it's about that presentation or something else. So again, to introduce the topic, we're going to be focused today on looking at DMX before and after a procedure and trying to make sure we're comparing apples to apples so we get a good reading of what it is we're seeing. So let me go ahead and start that here. Okay, so I will start sharing my screen and start this slideshow here. So we're going to be talking today about if your overhang, and we'll talk about what that is, on DMX improves, and you're trying to see whether or not that improvement happened due to, let's say, a procedure you had. You would want to make sure that you're comparing the same kind of view to the same kind of view, or apples to apples. And this is a problem because I tell you, I've made this mistake occasionally where you look at a DMX before, you look at a DMX after, and you're not really comparing apples to apples. So I'd like to show you what it is I mean by that, and hopefully you'll learn something as well. So DMX is digital motion X-ray. It's a specialized unit that allows you to see the bones of the neck moving in real time. And the good news about that is that it provides some information about cervical instability. And just going to start with some very simple anatomy here, right? We have the skull up here. We've got C1 there. We've got C2 there. Now I show C1 this way because this is the way it appears on X-ray. And so the dens of C2 sits in the middle of the lateral masses on either side of C1. And what we're going to be talking about today is overhang. And that's going to generally measure the strength of the alar ligaments. And those are supposed to be strong enough to hold your head in C1 and prevent that from slipping on C2 as you bend your head sideways. So a normal DMX, we're looking at this, what we call C1, C2 overhang, or open mouth cervical lateral bending, is we want to see that C1 stays lined up with C2. Now, if there's overhang, the skull and C1 will shift one direction, the direction of the bending, lateral bending, and that will no longer line up with C2. And we call that measurement there overhang, or OVH, we'll call that. And so that can determine if you've got atlantoaxial instability or craniocervical instability. And the max measurement there is 2 to 3 millimeters. So again, anything more than 2 or 3 millimeters, we start to get concerned about the diagnosis of craniocervical instability. And we've used before and after DMX as objective data, especially when the patient isn't 100% sure that they made a full recovery, or that they even improved, we'll try to go ahead and look at the repeat DMX overhang to see if there's enough improvement to proceed. But you've got to be really careful there, because there's a pitfall that you can get involved in. And I've made, like I said, I've made this mistake myself, where you have to make sure that the patient is laterally bending to one side the same amount on each image. So I'll give you a good example of that. This is a DMX, and this is not a treatment we did. This was done by a posterior prolotherapy clinic. And so this is their before images up here. That's the patient's skull. That's the patient's skull. This is going to be C2 down here. And these are the lateral masses of C1 as their head and neck is bending towards that part of the screen. So you can see there what it is I'm looking at. Now, if you look at here, that's the overhang, this one going that way. So C1 overhanging C2. Now, if we look at the before image and then compare it to the after image, the amount of overhang there looks a little bit less, so that's good. And the other thing we want to compare is what we drew this, I drew this line to see how far over the person's head was, what angle their head is at. And the good news is that that angle compares between the two and looks pretty similar. So we can say this is a real effect here, a small change in overhang. Now we go down here, however, to the bottom two images where the person's going the other direction, and we see the overhang is really big here. And we go to the after image, and it seems to have decreased. Now, the problem with that is that if I take this angle of how far over that bone is, or how much they're laterally bending that direction, and I superimpose it on the June image, you can see it's really off. The angle now is more like this. So they didn't go as far in this after image in June 2022 down here. So we don't really know if that overhang is real or a function of the fact that they didn't really bend as far. And so that's an important thing to make sure of, to keep us all honest, and anyone that does treatments and then looks at before and after DMXs, to try to make sure that we're getting the same amount of bending in each one. Now, sometimes that can be operator error on the part of the guy that did the DMX. Obviously, it's got to be caught on the part of the guy that's reading the DMX. So, good thing to keep in mind as we think about these treatments and how to objectify improvements in treatments where we can reduce overhang. So again, in summary, make sure that any repeat DMX is comparing apples to apples, which is, in this case, the same angle as the DMX is taken from before and after that DMX procedure. So let's stop the sharing here, and I'll go to see if we've got any questions. Okay, so we've got two questions. It's been advanced by Harry Winston. What's the average improvement DMX after the first PICL procedure? Yeah, if we're looking at overhang, Harry, we're generally seeing about 1/3 to 1/2 improvement per procedure. That can sometimes go as low as 25%. So let's say on average about 1/3 per procedure is what we're seeing. And then it's been advanced by Carlisle Morgan. Is there a difference between a DMX with cats and elsewhere? You know, we've seen lots of good places around the country that do a fine job of taking DMX studies. Cats is definitely one of them, and it's It's a known quantity. We know they do a really great job. But there are other places too that do a great job. So if we're in a situation where we've got a local DMX that we know doesn't really do a great job, we'll have the person come out here and get one by CATS. If we're in a situation, however, where we have something locally where they do a really great job, then we will go ahead and obviously just have it done locally, because that's always more convenient. So CATS does a great job. There are other places around the country that do a great job. Other questions that I can answer. I'll give that a minute or two to see if anyone has any questions they would like to ask me, whether it's about this topic or really anything else. Okay, well, we will start wrapping it up early today. I think we must have a lot of folks on vacation, which makes sense. We're sitting in mid-July here. So the topic today was looking at trying to make sure we're comparing apples to apples when we are looking at repeat DMXs. Oh, here's some questions. Let me grab those. Dan, does ensuring that the patient is not rotating head during DMX scan, lateral bending make a difference? Yeah, Dan, that's a really great point, and one I didn't bring up today because as usual, you're on to the advanced biomechanical topics rather than just, you kind of skipped over the easy stuff. So you're right. So as the person bends their head to the side, we've got to keep that head straight forward. And a lot of times what we'll see is as patients go ahead and bend their head, they tend to rotate it as well. So we do have to make sure that the head is absolutely straight forward as that person is bending. And a good DMX site will make sure that's happening and correct the patient if they're starting to rotate, because that rotation is going to change what it is we're measuring. So thanks, Dan, for bringing that up. Again, as usual, you're usually 3 or 4 steps ahead of the curve there. Jenny, can you do PICL when other affections or infections like Lyme were diagnosed? Yeah, we have patients who certainly have diagnoses of Lyme disease. It's an auto transplant, so we're taking stuff from one part of the body and putting it in another. So presumably it's not going to make any difference, obviously, from that standpoint. We also, for some of our Lyme patients, have actually used doxycycline in the mix, because we've got microgram dose doxycycline that we use for other purposes in the lab and in the clinic that's specially compounded. So we can do that for those patients as well. And we've done that for select Lyme patients here and there. Kristen, how often do you see increased laxity at 3.5 months PICL? I'm seeing some gains, went into alignment on my own the other day, but overall I feel looser. I know I have felt more gains later, but the majority see it at 3 months. Not sure what you mean by looser or feeling looser. I think what you may mean is not increased laxity like we're talking about it here, but maybe decreased spasm. So what happens with instability is when there's a lot of instability, there's a lot of spasm. So the patient's very tight, meaning the body is trying to tighten everything down to protect what's happening in the neck. And obviously, as things get more stable at that spot, the amount of spasm is going to go down, and that may be perceived as being looser. But there'd be no mechanism for increased laxity with something like this. It's either not going to move the needle or it's going to make it tighter. And then when do we often look? Depends on the patient, usually 4 months. For younger patients, we've done 3 months. And for some patients, they haven't noticed changes until 4 to 6 months. Sure. Okay, any other questions out there that I can answer today? Sure, Kristen, happy to answer that question. Okay, just to keep things going here. Here we go. Anyone that does DMX in Utah, you know, Carla, who's my assistant, has a master list that she keeps of good DMX sites. And if you're looking for a digital motion X-ray, though, let me see if we can just go ahead and look, because, you know, really Google is a great place to find stuff like this. So let's just look here for a second. So let's go. DMX, and I usually type in cervical with that because DMX is, as I think is a recording artist as well. So that'll mess things up. So if you type in DMX cervical Utah, yeah, advanced injury solutions, digital motion X-ray of Utah. So it looks like there's a couple digital motion X-ray at the Stand Ridge. Well, that's probably not Utah. So this would look like your best bet. Now, what I would do is contact my assistant, Carla. And yeah, we've worked with these guys. These guys do a good job. So I could give them a thumbs up right here. So they do a good job. So yes, there is one in Utah. That's who you would go see based on what we've seen come out of that clinic. Let me stop the share here. Daniel Iverson, is the radiation from DMX dangerously high? No. So that's a good point. Let's kind of rank radiation exposures here, because I think that's something that's good to discuss and good to sort of understand from a bigger, excuse me, picture standpoint. And let me share the screen here so we can do that. Not seeing the other one. Well, tell you what, let's go. Let's do the entire screen. Okay, so if we look at radiation exposures here, and we create sort of a graph going out this way, to the right is going to be the highest possible radiation exposures. Let's get a different one going here. Okay, to the right is the highest possible radiation exposures there. So off to the far left here, we'll put just daily life, walking around doing nothing. And that's going to clock in as our baseline there. So hiking outdoors, spending as much time outdoors as the average American spends. Then next over is going to be the amount of radiation that looks like you're not seeing my screen. So let me fix that. Thank you, our trusty observer there. Okay, let's try that again. So again, daily life over here, someone who flies for business, because you get more radiation exposure as you go higher up. And then a pilot running a fairly frequent route. So let's say that's a cross-country plane route. They're flying that a lot. So they're probably flying it 3 or 4 days a week, several times a day cross-country. So they're going to get more. And then in that same range would be something like a chest X-ray. So that's going to be very similar there. And probably just north of that is going to be a DMX. But realize that a CAT scan is going to be way, way, way up here. So that's always an interesting conversation, because many of the patients, obviously, that we see have had CAT scans done many times, looking at their internal jugular veins. So the answer is, if we put a DMX over here, a DMX does have more radiation, I think, than the average chest X-ray. But it's got a lot less radiation than something like a CAT scan. And if we go to our frequent flyer pilot over here, probably not that much more than that frequent flyer pilot is going to get. So that's a good way to get a sense of what kind of relative risk we're talking about here. And hopefully you guys were able to see all that. Let's see. Yeah, hopefully I fixed that there. Thanks, guys, for letting me know. Anya, hi, Dr. Centeno. What's the difference between instability caused by trauma, rheumatoid arthritis, and EDS? I know that Dr. Worldwide treat trauma and RA instability, but rarely treat EDS. Yeah, so we see EDS patients all day, every day. I would say probably 1/4 to 1/3 of our current CCI population that we treat in clinic has EDS or HEDS. What's the difference in instability? I mean, EDS patients are going to be more lax every place, usually, sometimes not always. And hence, they're going to be a little different than someone who has normal ligaments and then gets a specific injury and stretches out that normal ligament with that specific injury. As far as healing from something like a PICL procedure, I think, as I've said before, we looked at that data last year. We didn't see a big difference. We're currently looking at it again, but our research team's got a lot of balls in the air right now, so I don't really think I'll get that back till later in the summer. And when I get it back, I'll certainly share it. My overall opinion is, since I already did my own look at this probably about 8 or 9 months ago, where I looked at failures, trying to see if there were more HEDS patients in that failure group, and there weren't. So my overall sense is that probably what we'll end up finding here is that HEDS patients respond more slowly, need more treatments, but in the end, likely get to a similar place to those people who don't have HEDS. As far as RA, we haven't seen a lot of RA upper cervical instability at this point, so I can't really comment on that one. I have seen an awful lot, obviously, of upper cervical instability or CCI patients, and that's both those with HEDS and not. Joni, what about radiation versus an MRI? An MRI uses electromagnetic energy, so not radiation. Now, radiation is a form of electromagnetic energy, but it's higher frequency. So too much radiation can cause problems. But a magnetic field or electromagnetic field like is generated with MRI is generally considered to be safer than just using an X-ray. So that's the reason why a doctor might push you towards getting an MRI versus a CT scan. If the MRI is going to show as much or more, then that would be the way to go. And because it doesn't expose you to all of that sort of massive doses of radiation that a CT scan can. Other questions out there, guys? Anything I can answer? Okay, well, we will wrap it up in record time here then. I think we got a lot of folks on vacation. So again, what we were talking about today was trying to make sure that when we're comparing DMX, we're looking at apples to apples. So one of the things that can happen is that when you get the repeat DMX, you're not bending as far. So if you get a repeat DMX to try to see if the procedure works or worked, make sure that you try to bend as far as you possibly can. Obviously, we'll look at it on our side to make sure that that one's really happening, because we want to make sure we get as much lateral bending, because that lateral bending is what can push that C1 over C2. So if we're going to compare it, we need apples to apples, or as much lateral bending in the first one as the second one. I just had some questions come in there. Anya, you shared previously that your knees got better with injections. Would you say you know other people with EDS who got better and no longer need injections, or need them rarely, or do EDS people from your experience, generally speaking, need injections once a year, a few years? Thank you. Yeah, Anya, I mean, from what I've seen, we get EDS patients to a steady state, not just my niece. And once they're at that steady state, we might touch things up here and there, but we generally don't go through a whole nother big round. So, for instance, to give, I think I've already given my niece's experience with this. We started with some simple prolotherapy. We then moved to bone marrow concentrate for the really bad areas. Then we sort of did some touch-up work, and then she got active enough and strong enough on her own where she started to get better muscular stability. And I don't think we've done a touch-up here in the last 2 years or so, but some of that's due to COVID. So my sense is if I see her back here in the next year, it might be to do a touch-up here or there, but nothing like we did when we were really going to town and treating 5, 6, 7, 8 different areas at once. Anya, I also wanted to ask about fused facets. If they are fused, will it be visible on scans or only during the procedure? Usually a fused facet is visible on an MRI. It's also visible on a CT scan, sometimes on X-ray as well. Tends to be more visible in fluoroscopy than routine X-ray because you've got more angles and you can change that and try to see if there's a fused facet. So, but general neck imaging, MRI, things like that will generally show fused facets. Joni, thank you. I'm trying to get an MRI so I can come and do treatment with you. Been so dizzy. Hope you have success with dizziness. Yeah, Joni. So as you probably have heard, dizziness is a major symptom of CCI, and a lot of CCI patients have a lot of dizziness, and it's because the upper neck supplies information to the brain about head and neck and eye position, and all of that's got to coordinate. And so when there's an issue up here, there's can be an issue with balance. So yes, we have good success with dizziness in obviously treating the upper neck. Levon, if difference between EDS and normal PICL in terms of result is similar, does that mean that EDS and normal ligament is similar to begin with? No. So my sense is, again, Levon, as I think I said, that I think that EDS will require, my best guess is once we look at all this and have all the data in, EDS patients are going to require more treatments to get to the same place. As far as the person being at the same place, no, EDS patients are going to always produce structural ligaments. So the goal is to make those ligaments bigger so that they're stronger. And in addition, almost all EDS patients have time periods in their life where things aren't bad, and then things start to unravel. And as they unravel, it's because of a lot of different reasons. Sometimes it's a small injury in a specific area. Sometimes it's because something like this happens, and then that impacts the stability, the muscular stability in the rest of the body. So no, EDS patients are not like normal patients. And even when their ligaments are injured, that's going to be different. And then when their ligaments are healed or better or stronger, they're still going to be different than that of a normal person. If the neck and shoulder muscles are in spasm, so it's hard to bend the neck laterally. I had X-ray lateral bending last week. I'm in Europe, but not sure I was able to bend my head far enough. Yeah, there is something that can be done about that. The biggest thing to do, in my experience, is to take 10 or 20 milligrams orally of Valium. Obviously, at least in the US, you've got to get that prescribed through a physician. You would need a driver to make sure that things are good. You may even want to test it out beforehand. So get a test dose from a doctor or a pharmacy, take 10 milligrams, see if that allows you to bend. If that's not really moving the needle, you can go up from there, obviously under the supervision of a physician, making sure that dose is okay for you. And get to a dose where the muscles are relaxed enough where you can get that maximum lateral bending. But in our case, usually 10 or 20 milligrams of Valium will make that work pretty easily. Okay, guys, and I do have a short time period today anyway, so I do have to get moving. Well, thank you so much for watching today. I appreciate everyone's time. And at the end of the day, we were just talking again about how if you're going to take a repeat DMX, looking for lateral overhang or C1C2 overhang, we got to make sure that we get your head bent as much to the side or the other side, so that's the same to the first study, so that we can really see that we're comparing apples to apples. I think I will be here this Monday, and I wish you all a wonderful weekend, and let me know if I can help. Thank you.